So talk to me a little bit about what was your rationale for pursuing this study? What was the question you're trying to answer, and how did you come up with it?
Background for kidney injury molecule 1 is that it's a biomarker that's detectable in the blood and actually has been investigated for kidney cancer by multiple people, including our group in the past. And it the biomarker itself is a transmembrane protein, which is found on the cell membrane and is cleaved off by metalloproteinases, has a little domain that circulates in the plasma or serum and can be picked up by different assays. And so there's quite a bit of prior data showing that in patients with kidney cancer, KIM-1, as we call it, is elevated in the plasma and can be picked up as a biomarker, kind of similar to how we do other tumor markers like PSA or CA-125. In the kidney cancer clinical area specifically, there is a dilemma for lots of patients who have a renal mass where you don't know for sure if the renal mass is benign or malignant. And in this situation, kidney biopsies are not always that specific because you can have a false negative biopsy. What we find is that when you look at large cohorts, consistently, there's a significant proportion of patients, maybe around 25%, who have a partial nephrectomy and end up having a benign mass. And so that's what we're trying to avoid. In this paper, we look at kidney injury molecule 1 as a way to risk stratify masses. Are they likely to be malignant? Are they likely to be benign? Are they likely to be indolent? To try to pick the patients that would benefit the most from surgery.
And this KIM-1, just for clarity, is this something that we find in all kidney cells, or is this kidney cancer cells, or kidney cells that are undergoing injury based on its name?
Yeah, the name is descriptive. It's kidney injury molecule 1. In patients who are otherwise normal, so in healthy volunteers, KIM-1 is not elevated. It's not expressed in the kidney normally, but it is overexpressed when the kidney undergoes hypoxic injury. And the first papers for KIM-1 described it in patients, for example, who are going cardiac surgery and had a cardiopulmonary bypass and kidney hypoxia. We see that in patients with kidney cancer, a lot of these same hypoxic pathways are upregulated, leading to overexpression of KIM-1. And so that led to its use as a biomarker, specifically in kidney cancer. And among the patients who have kidney cancer, what's interesting is that because it's a kidney tubular epithelial protein, it's elevated in both clear cell and papillary kidney cancer.
Really exciting. I mean, that's really the first marker potentially for papillary that we've seen, which is great. And you've looked at two different cohorts here, one in Russia, correct, and one in Johns Hopkins. And you've looked at a wide variety of sizes. The Hopkins cohort, smaller renal masses. The Moscow cohort, a little bit more variety, larger masses. Tell us, what did you find with KIM-1? What's its significance there, and what are the takeaways from the study?
One of the exciting things that we learned from this study is that plasma KIM-1 is elevated in both patients with large and small renal masses. So it is one of the first circulating minimally invasive biomarkers that actually is elevated even in TT1A, 4 centimeter renal masses. What we do see, which is not surprising, is that the elevation is more in the really large masses. And that's probably consistent across all circulating biomarkers, where biologically the bigger a tumor is, the more material it's likely to shed into the circulation. And based on prior studies, we know that the more tumor there is, the more KIM-1 is elevated. And so, for example, when we looked at prior metastatic settings, patients with metastatic RCC have several orders of magnitude higher KIM-1 than what was seen here.
Interesting. So in these oncocytomas potentially that we're following in patients we don't want to operate on, the larger size in those, is that going to be, is KIM-1 maybe even more helpful in that setting than your 3 centimeter mass?
It could be helpful if you're trying to find out if it's an oncocytoma versus a more aggressive malignant mass. We don't have KIM-1 produced by oncocytomas because oncocytomas have a different cell of origin compared to clear cell or papillary renal tumors. So it is a helpful assay if the differential diagnosis is oncocytoma versus, for example, papillary kidney cancer.
And I know you didn't look at this, but do you see there's maybe a potential here with combining this liquid biopsy with some of the imaging that's coming out, like CA9 or Cystamib? Do you think you might have some added benefit with combination of those, or what are your thoughts on that?
Absolutely, Dr. Joyce. That's such an important question. Carbonic anhydrase 9 girentuximab-based PET imaging was presented at GU ASCO recently. Really exciting data showing that it has sensitivity and specificity for detecting clear cell kidney cancer. And biologically, you would expect that these two assays probably have some additive predictive capacity where a mass that you're not sure of, if it lights up on PET and expresses KIM-1, is probably highly likely to be a clear cell renal cell carcinoma.
Hmm. One of the limitations you mentioned in your study is that obviously this KIM-1 is elevated in patients who might have kidney injury from some other reason besides cancer. And often these patients were discussing active surveillance versus operative intervention. These are patients who may have CKD and other issues that kind of make us hesitant to move forward with treatment. How would you view this marker in the setting of those patients? And is there some work to be done where we could differentiate a little bit those levels based on patients with pre-existing kidney injury?
I agree. Kidney injury molecule 1 is elevated in CKD and AKI, but I think it's important to understand that it's a different degree of elevation. For example, in patients who have renal masses that have confirmed clear cell RCC, when we correlate the KIM-1 levels with creatinine, there's actually no correlation whatsoever in those patients because the amount of KIM-1 produced by the tumor really overwhelms the amount that's produced by the normal kidney. It's a different order of magnitude. However, in patients who don't have kidney cancer, then absolutely the levels of KIM-1 are correlated with ongoing kidney hypoxic injury. And one approach that might be useful in the future, especially for patients where you're not sure if they have cancer or not, is to measure multiple kidney injury biomarkers. For example, cystatin C, creatinine, KIM-1, and that could help to control for the ongoing kidney injury and to help differentiate, is the KIM-1 coming from hypoxic kidney or is it from a small tumor?
Fantastic. Well, I mean, this is really exciting stuff. I mean, just to have some sort of signal here from a liquid biopsy to help guide our treatment in this tough clinical situation. We're still over-treating these masses a lot, and it's nice to have some new technology on the horizon that might be helpful. Where are you going next with this work, and what do you see the next steps are here?
I think it's really exciting to see that we're starting to have data on KIM-1, not just from retrospective studies, which this is, but also from prospective and randomized adjuvant trials. We have data on KIM-1 that's been presented for the ASSURE adjuvant trial in RCC, as well as more recently, the CheckMate 914 adjuvant trial. And in a couple of weeks, we'll see data at ASCO on KIM-1 in iMotion 10, which is the adjuvant atezolizumab trial. All these trials have shown that KIM-1 is prognostic, and in some of the immunotherapy trials, KIM-1 is actually predictive for adjuvant immunotherapy benefit. So this is a really exciting field where we know that, first of all, adjuvant immunotherapy with pembrolizumab has a disease-free survival and overall survival benefit on the one hand. But on the other hand, we also know that lots of patients are overtreated, and over half of patients would not have had recurrence even if they didn't get the pembrolizumab. And so I think this is a ripe opportunity here to pick patients better. On the one hand, identify patients, for example, who don't need adjuvant therapy, and on the other hand, maybe even find patients who would not be eligible for clinical criteria for adjuvant therapy, but have a high KIM-1 and might actually benefit.